absolutely obsessed, and will always kind of credit MPI for basically everything that I ever get in this profession. And I think Brett could probably, say the same thing. And so we're going to kind of talk about the hip, a little bit of biomechanics, some assessment, maybe a little treatment. And if you get any questions, you can kind of stop us, or if you want, you can put it in the chat, and Jake can kind of help moderate for us. So
perfect.
Anything else?
No.
Let's just mow right along. I guess where we practice is Winchester Spine and Sport. It's in Troy, Missouri, so it's about 45 minutes west of St. Louis. We have kind of an integrated clinic. Basically, there's 3 sections. There's functional trainings. We have like an 800 square foot gym where we have two full-time trainers and a couple part-time trainers that we do small classes with, as well as one-on-one training. And then we have functional chiropractic in the middle. We have 5 chiros. Myself, Brett, Dr. Jordan, who mainly specializes in pregnancy and pediatrics, Dr. White, who played baseball in college, and that's kind of his little niche. And then Dr. Panner, he's big into golf. But between the 5 of us, we see a pretty diverse population. And then our last one is we have functional medicine as well. So Dr. Furlano is our amazing functional medicine specialist. And so between it, we kind of have 3 pillars, and we like to try to get our patients to touch each one of those pillars. And so it's not as relevant with the hip, but there's a lot in functional medicine that we kind of talked about if you cut our talk about the shoulder. So
we are they going to see us or not? Okay. So I always tell the story on the hip. The first time I saw a professional athlete was a hip case, and I was definitely nervous, blah, blah, blah. And so anyways, this patient ended up having femoracetabular impingement, although 20 years ago, no one knew what it was. It was barely being described. So anyways, I worked on this guy, 8 times, and I just could not will this dude better. And so he goes to spring training. Of course, he's no better. So I'm keeping in touch with him, and he ends up getting sent to Philippon at the Hawkins Stedman Clinic in Vail. And so anyways, that was the first time I heard of femoracetabular impingement. No, we definitely were not taught it in school, nor did no one really knew what it was. And so he was basically the expert in the world at the time of describing it and doing the surgery. So of course he has a surgery and just does amazingly well. And so it was interesting, you always want you're always kind of rooting for certain cases. And my first big profile case, I basically fell on my face, and but it was quite a learning moment. And I would say because of that, I really, dove in and tried to really understand the hip. Since then, I've been lucky enough to talk to Dr. Thomas Bird, who's kind of the expert in Nashville. He works with a lot of NHL players and PGA people with hip problems. Philippon's one of his big fellows, Dave King, not Mark King, but Dave King is in St. Louis. So we had many good conversations with him when I was with the Cardinals about the hip. And so that's I feel like it's a very undertreated area in our world. We don't diagnose it well in chiropractic. We actually don't manipulate the hip very much because it doesn't cavitate, which is a huge mistake. So we do believe you should be manipulating the hip, but people don't because it doesn't sound off like an SI joint. And it seems like as a profession, we struggle with on the best ways to train the hip. So it's a really nice little progression if you think about it for strengthening, where, we use a family of maybe 5 or 6 DNS exercises after they've been taught intra-abdominal pressure. And then we transition them into a gym into, one-leg, two-legged hinge patterns and Turkish get-ups and goblet squatting. And really, it really works good as far as like just kind of a continuum of care, I would say. So to start off, so the hip, so this is kind of our there's a lot of stuff that can cause symptoms in the hip. There's a lot of differential diagnosis in here, some of it nasty, some of it not, but this is a really good picture out of I just forgot his name. McGee's textbook, Orthopedic Physical Assessment. And it just kind of gives you an idea, all the way from aortic aneurysms to, vascular pathology in this area can cause just some weird symptoms. So. You got to watch too. You can see in gray on this picture, you have some key lymph nodes here. So these lymph nodes can become problematic with like testicular cancers and other things. So you can definitely palpate these lymph nodes. So it's something to take note of. Obviously in the younger population with like the MPI reps, like your guys' age, I mean, that's who we really worry about testicular cancer on that age group. So be aware of that because it can act like anything. And then also you have the whole family of hernias that also can, make diagnosis difficult in this area. And then we have, of course, the infamous sports hernia, which is basically a traditional hernia, but it's not significant enough to where it's actually broken through the abdominal wall. And we have a guy named Dr. Brunts in St. Louis at WashU here, and he's becoming the guy. And there used to be a guy in Philadelphia everybody went to, but so it's kind of interesting to see. That was kind of like the hot button diagnosis 10 years ago, the sports hernia. So with, as DNS has grown and the training of intra-abdominal pressure has gotten better, we are definitely doing less operations on the sports hernia than we were 10 years ago even. So, it just comes back to good rehab and good treatment a lot of times, and, gets a lot of these cases better. And I would say that's probably it as far as the serious things. And then I would just add one more thing on the older patient. You can definitely still walk around with a fractured hip. So we have to really kind of be careful in the geriatric population if they've fallen or anything like that, we get the appropriate imaging for the hip. So.
Yeah, and then this slide it's a non-negotiable. It seems like every time Brett or I give a presentation, this is kind of like the first starting point is it needs to be known. It needs to, especially when we're talking about the hip. So this Expo study which we can all kind of cut it apart. We can, there's lots of other things we can say about the actual study, but the relevance is that symptoms around the hip are rarely actually hip. Which is kind of crazy to think about. But if you look at that number, 71% of the patients they looked at, 322 patients that had symptoms in their hip, it was coming from the lumbar spine. And so do yourself a really good favor, especially as a young doc, and I will put my hand out there, learn from me, rule out the lumbar spine, because a lot of times that patient that comes in with pinpoint pain in the hip, that it seems like FAI or it seems like you name it, it's coming from the spine. And so you can work some really good miracles by ruling that out.
Yeah, a good way to think of it is, because they basically looked at people like coming into primary care. So if your patient came in and literally put their hand over their hip and said they had a hip problem, 7 out of 10 times that ended up being a lumbar spine problem. So that is really, really important for differential diagnosis. Just in case we don't say it, the hip joint classically is a referral pattern that is in the anterior hip, into the inguinal canal, and into the groin. So whenever a patient comes in and they're pointing kind of backwards posterior to the hip joint, the posterior hip joint does have pain generators back there, but it's not often the case. So just do yourself a huge favor and be sure, as Taylor said, to be sure that you have made sure that those symptoms are not coming from the lumbar spine. What throws everybody is that people can only have pain like over their SI joint or in their posterior hip joint without having an actual spinal complaint. So that's where people get thrown. I mean, you have the obvious one where people have a stiff low back and they have lumbar spine pain with hip pain. That's easy. That's not the one people are missing. People are missing when they only have a hip problem. Now, this picture that you're looking at to the left, this is also from Dave McGee's, all of his editions of his textbook. It is showing that, like the knee joint refers up, and I can't say that I 100% agree with that now that I've done this for a while. But I will definitely say, like we just said, it can definitely refer downstream, but the hip joint also just doesn't really refer up. So if if your patient is pointing to their SI joint or into the lumbar spine, I have kind of closed the door as far as the hip being their pain generator. Now, the hip can be dysfunctional, of course, but as far as it being their actual pain generator, your chances are going way, way, way down with that. So I'm going to go through just a couple of our favorite research topics or papers on the hip real quickly, because I know we're short on time, but here's the clinical prediction rule for hip OA. So what they're trying to do in research is kind of doing away with orthopedic testing and kind of doing these CPRs, which is basically, what is the family of things that are congruent when we see these diagnoses? That way it kind of helps make the diagnosis accurate. So You have number one, limited active hip flexion. You have active hip extension causes hip pain. You have a limitation in medial rotation, and you'll see as we move along here, that's also one of the first things to help diagnose femoracetabular impingement. Squatting's limited and painful. I've definitely found that to be true. And then if you look at any of Stuart McGill's textbooks, you'll see that he was kind of the first one to really start to describe the scour test. And with the scour test, you get pain with adduction. The truth of the matter is, in practice, you kind of combine hip flexion, adduction, internal rotation together to kind of get you to that femoracetabular impingement or hip OA diagnosis. But anyways, in the clinical prediction rule, these are really helpful for students, by the way, because if you're a little bit confused, you could look at this, and if you got 4 of the 5, then you know that you're dealing with somebody who's got hip osteoarthritis. Now, and again, that doesn't mean that you can't help them, but it does mean that that's what the diagnosis is. And then, you give them a really good trial of care. I would say treat them twice a week for 4 weeks, and then reevaluate. If they're not 50% better, then get some imaging or maybe change your approach. So the other thing, and we're finding this true throughout the body, is that exercise, and here they looked at land-based exercise, is critical for people who have arthritic hips. The reason I throw this in there is because it seems like a no-brainer, but a lot of our patients, if we ask them, what should we do with you now that you have severe osteoarthritis in your hip, most of them are going to tell us that they should shut down. So that is the exact opposite, and the knee's the exact same way also. We're finding out actually people will benefit with a light jogging program who have severe osteoarthritis in their knee joint. So we want to be careful in what we tell our patients and to think that they need to be resting or being careful. When you see land-based, it immediately makes you wonder, how does this compare to water-based exercise? The reason land-based exercise is beneficial is in the aging female and male, obviously, to kind of guard against osteopenia or osteoporosis, then loading our bones is helpful. So we want to always keep some kind of land-based exercise program in place, or at least be working toward that, depending on what stage of the case it's at. This is a paper every one of you should have, and basically this is kind of a famous paper. It came out, basically when I was just getting into practice, and I still remember it. Ireland, who gets credit for this paper just because of the first name of her first letter of her last name. There's also another famous author on this, Irene Davis, who's a big minimalist running person. But anyways, what they found is subjects with patellofemoral pain demonstrate 26% less hip abduction strength and 36% less hip external rotation strength. So basically, and I just want to add one more. I know we're talking about the knee, but my experience with patellofemoral pain syndrome, if diagnosed correctly, it's going to be females between the age of 12 and 30 who have hip aneversion. All right, that is basically, until proven otherwise, if they have been diagnosed right, that's what you're dealing with. If we can give them really, really good hip strengthening exercises, and I'm biased toward DNS for this part of it, then these patients get better, and they get better quickly. So, but again, I mean, I think it's why we are so bought into the Kinetic chain. I mean, this is just one more paper to tell you that we have to look outside the place of pain, and then here we're talking about strengthening the hip joint.
And we'll get into how to kind of assess for aneversion and stuff in a bit. So.
I like this paper. This is 10 years old, but it was really good. What they tried to do is they tried to find out which exercises are the best for activation of the glute medius and glute maximus. So it was interesting for the glute medius. I mean, I never really give this to a patient unless it's an older patient, because there's just better options with DNS and other things. But so the best exercise they found for activation of glute medius was simply laying on your side with a straight leg and abducting your leg. So the problem with that might be is it's just not a very functional way to exercise the muscles around our hip. And what I mean by that is sometimes you do a maneuver, and although you have really good activation of whatever muscle we're talking about, it's not training the family of muscles around a joint. We see the same thing in the shoulder, where you have people strengthening the rotator cuff on their side doing that. And there's no doubt you're going to activate your infraspinatus by doing that. The downside is you're not synergistically picking the muscles how we want it to do when we're, doing our sport or just moving around in our life. So something to note on that. As far as the glute maximus, they found that the single limb deadlift exercise, which is just an amazing exercise, if it's trained with intra-abdominal pressure and with making sure all the joints are in centration, this is a great little progression for a lot of cases. And this proved to be one of the best ways to activate the glute maximus. I don't know if any of these people are from California, but this Fredrickson, he was a researcher from Stanford, and he was kind of the guy or the guru who had studied IT band syndrome early on. And basically what they found out in his paper was that if you took people with IT band friction syndrome and we strengthened them, I think it was, 22 of 24 athletes were pain-free at a 6-week mark. So that means you could just forget about everything you know about manual therapy. If you took 26 people who have IT band friction syndrome who've been diagnosed correctly, you just strengthen their hips. And in this paper, it was not an impressive strengthening program, by the way. But you're almost batting 100%. I mean, it's 22 out of 24. That's really good. So anyways, that's just another paper looking at strengthening the hips. We'll pass. I'm gonna skip through some of these just for the sake of time, so we don't eat through all our time on this boring stuff. This was an interesting study from Julie Moorside and Stu McGill, where they basically found that just because you improve a range of motion on the table doesn't necessarily mean that it is going to cross over into their life or sport. I forget exactly what functional movement they looked at. So it's a good lesson for all of us who are, so into passive treatment, whether that's through manipulation and soft tissue work or mobilization, which we all are. But it's really important that we come back and kind of regroove that motor program through really good targeted exercise. So in that paper, definitely said that. And then as far as structure, sometimes altering how we use our muscles throughout our body, this paper looked at people with femoracetabular impingement, and they found out that they have altered hip and ankle loading patterns during walking. So this is where sometimes the structure of the hip joint, you're not going to get around. And that is why in a certain subgroup of people, they will require reshaping of the femoral head and labral repair with surgery. Okay, so I don't want to insult your intelligence because I know you guys all know this, but it's an important concept to kind of review. We talked about it with the shoulder. When we are open and closed chain function or talking about these two things, then it's an important idea to know what we're dealing with, because you're going to change how the muscles are going to be pulling depending on what situation you're talking about. So if we're talking about, I think the next slide we have it. So if you're looking at the group of pictures on the left, then you're basically looking at, how you learn movement in school in an open chain function. So if you looked at all these 6 pictures on the left, basically all the muscles are going to be pulling proximally. Now, conversely, if you look to the picture on the right, when you have the foot or you have distal support, now all the muscles are pulling the opposite way. And that's a really, really important point. That's something that we really teach a lot in DNS, because the brain or the central nervous system is always usually going to be doing one of these two things. It always will be. So understanding, which way we want the muscles to pull sometimes dictates how we're going to rehab the patient. So not shockingly, a lot of times our patients are used to doing open chain exercise, and they need to be doing closed chain exercise, and we need to be teaching their brain how to pull their muscles the opposite way. So you want to do away with origin insertion and think of it more of like an attachment to where a muscle is, because it's always changing depending on whether it's open or closed change. Okay, so these are just mensuration angles. This is not important for today's discussion, except for the fact that if you are looking at, X-ray or have access to X-ray, this could tell you that the developmental kinesiology maybe wasn't ideal. So you can see, if we look at the angle of inclination, you know, we all learned for boards, it should be 125 degrees. People who do not have the proper development, so if you looked at one over to the right here, then these people, their hip joints actually have more shear stress across the femoral neck. And then if the angle's too great, like we see in coxa valga, then you can almost just reason it there. It's now more load actually at the femoracetabular interface there. So it does kind of matter. What can you and I do to change it? Not much after the age of 4. However, it can help us maybe know that the developmental kinesiology was not ideal.
And maybe predict like what things that they're going to come in with, or what things are maybe susceptible to that you may add a little insurance policy in there.
Yeah, exactly. So, and then you can see this picture here just kind of shows like, you know, when you're born, we have 100, this says 150, should be 160. So if you have 160 degrees, as we're moving through our development, then this angle is getting to its normal spot. So it's basically becoming more acute, like you see in the 120 degrees, which is all what we learned for boards. Now, this is a really, really important point. So angle of anteversion, which is a little bit more important than the angle of inclination that we just talked about. So the normal angle of anteversion should be between 12 and 15 degrees on a typical human being. So we were talking about before with patellofemoral pain syndrome, it is really, really, really common to see hip anteversion. And one of the reasons is because we do everything that we shouldn't do with our pediatric patients in the first year of life. And because of that, because of them being sat too soon, then what they usually end up doing is they get themselves into that W sitting position that I'm sure you're all familiar with. And that is one of the things that generates this hip anteversion. There's other things, but that is one of the things that can kind of help promote that. And like I said before, the downside, let me just get to the point. The downside of hip anteversion is that what it does, because of that angulation, your brain now has a decreased ability to activate the muscles in the posterior part of the glute medius and the glute maximus. So you're basically putting yourself at a disadvantage for being able to use those muscles. And because there's excessive internal rotation, let me see if oh, there it is. That's my favorite picture. So this is from Michaud's textbook here. You can see with, if the angle's too great at the hip, it causes an abutment between the lateral pole of the patella and the lateral femoral condyle. And that is basically patellofemoral pain syndrome in a picture form. So we said 10 to 15 degrees would be normal. And then you can see here why we see the compensation out of kids. So if you look at this picture that I have the cursor on here, you can see the angle of anteversion is too great, so 35 degrees. So what the body does to compensate is it's now going to try to match up these two red circles. So look over to your right there, and you can see now that these circles are matched up, but now that's internally rotated the whole lower limb. So when you see a pediatric patient who's walking with kind of a pigeon-toed presentation, there's only two things that can be going on. Either you have this, which makes up the lion's share, or you have excessive tibial torsion. So, you know, you can easily figure this out just with a good examination on which one it is. So, that. By the way, too, this is also what is leaving female patients susceptible to ACL tearing. So if you're the proud owner of one of these anteverted hips, you are automatically at higher risk for ACL tearing because, again, your brain doesn't control the muscles that control the femur very well, that being the glutes.
It's one of the biggest things that I'll bank when I'm at the high school working with athletes, especially the, like, you know, volleyball players and stuff like that. If they have anteverted hips, I know that I've got to give them some sort of something to do at home that's going to help to prevent that. Whether or not it prevents it or not, but at least something that is strengthening their hips so that they can control their knee in the frontal plane.
There's a famous knee surgeon, orthopedic surgeon in Cincinnati. His last name is, first name is Frank. Last name is Noyes. It looks like no yes, mashed together. But he, like 20 years ago, he had what was called a sports metric program. And he was 100% able to prove that if we strengthen these females that you're talking about, and we teach them how to jump correctly and land correctly, you will 100% make a statistical difference in people tearing their ACL. It's really kind of cool. I think, you know, everyone that's sitting on this, and ourselves included, you just run out of time. Like, I mean, in a perfect world, we would be up there every week training these girls, but like, since it's not necessarily exactly what we went to school with to do, then, you know, a lot of times we don't offer a service. Now, I did it when I first started. So I was specifically running an ACL tear prevention program. And basically it was weeks before the basketball season started of teaching them how to use their glutes. And then we also went through landing. When I say landing, the biggest take home is when you land from a jump, you want your center of gravity or center of mass to be in between your base of support, that being your feet. If you watch videos of females tearing their ACL, the thing you'll see across the board, you'll see their center of gravity far outside their base of support. And that's one of the other reasons why they tear their ACL. Usually you never tear your ACL in isolation. You're going to tear your ACL, your MCL, your medial meniscus, and a lot of times you'll fracture your patella. So here's the other one, which is more common in males, hip retroversion. So you can see this just becomes minutia a little bit. So they're still anteverted, but they're only anteverted 5 degrees. So we said the normal was 10 to 15. So they're now relatively anteverted, but we would call them retroverted. I know it doesn't make sense, but anyways, what this does is this blocks internal rotation of the hip joint. And this has been an absolute predictor for low back pain. So if you are assessing someone's hip internal rotation, whether it's functional or structural, and it's not there, they got lumbar spine problems coming. And there was 2 authors, one Michael Kabalka from, ironically here in Missouri, Festus, Missouri, and then another one, Shirley Sarman, who's kind of a famous PT here at WashU, and they both studied this, and they both have come to the same conclusion of lack of internal rotation will always lead to lumbar spine problems. Okay, so now we just want to, briefly talk about femoracetabular impingement. So you can see here, basically we have 3 main options. So you have a normal hip here. You either have camming. So when you hear the term cam, that means that the patient has added on bone to the femoral side of the hip joint. We have the pincer, where you can see here where they've added bone on the acetabular side. And then what you typically have most of the time is you have a mixed presentation. So now the $1 million question, how do we get to this point? How does this happen? So I had, this is where I had some really good conversations with Dave King and Bird. They believe that this is happening because of youth sports, most specifically rotational sports, at a young age with the growth plates open. So hopefully you guys all remember Wolff's Law from school. Wolff's Law basically means when you stress bone, what the body does is it actually lays more bone down. So you can imagine, like in a golf swing or a slap shot or a lacrosse player, they're taking the hip joint to in-range motions, and that abutment is causing them to lay down more bone there at a time when bone is really relatively fragile. So that's kind of the explanation. From DNS standpoint, we also believe that there can be a developmental reason why. And then finally, you have a genetic component. So I would reference you to Dr. McGill, where Dr. McGill's talked about, like, he can basically look at someone's hip joint and tell them what part of the world they're from. And that's why, like, a lot of times, like, our best Olympic weightlifters are from a certain area of the world. Other places like Scotland, they have really deep hip joints, and because of that, they don't make great Olympic weightlifters because they don't have that much hip range of motion. So this is this going to play?
Mm-hmm. Yeah, present.
So this is camming, a really good little video of what camming of the hip joint looks like. So you can see kind of the structure here. This is the labrum of the hip joint. So the job of a labrum is basically to increase the surface area of the interface between the bone and the femur and the pelvis. And it creates like a suction. If you can imagine, like a dart on a window. So once this is ruptured, you lose all like the negative pressure that's within there. And you can still function, but you lose quite a bit of stability. It's a really good picture showing that. So the downside of femoracetabular impingement is it usually culminates in a labral tear. And we've had some really interesting philosophical questions over the years, which is, if you had let's say that your son is the best hockey player in Canada, and you knew he had significant femoracetabular impingement, would you do a proactive surgery to prevent the labral tear from happening down the road if you knew he was going to, play in the NHL or get drafted or whatever it might be? It's not as an outlandish thought as you might think, because in a real significant case, you know that it's going to become a problem. Now, there's all kinds of risk involved. So the reason you wouldn't was, 1 out of 10,000, anesthetic risk, you have infection, you have, other problems that can go wrong with the surgery. But anyways, it's an important, not an important, but it's an interesting topic to kind of talk about. Here's the pincer. I forgot how good these videos were.
Oh no, they're so good.
So on the pincer, they're going to be adding bone. You can see the abutment here.
I think that's a good, a really good thing to keep stashed in the back of your head, because if someone does come in with FAI or they're having those groin symptoms, and you can reproduce it with, the Patrick Faber test or the scour or whatever it might be, you can continue to come back to those. If you do really good treatment for 2 weeks and you have no change whatsoever to that, you should start to be thinking all right, am I doing the right things? Where is this case going? And sometimes you just can't get around anatomy.
But in saying that, we were doing, 5 to 10 years ago, I was sending a lot of people for surgery. And now that I'm just better at what I do, I'm doing less and less. I'll definitely have a couple a year that I will refer to surgery, but it is definitely worth, even if they have a labral tear, going through a really good trial of care, because they're finding out with the hip labrum, just like we learned with the shoulder and the meniscus of the knee and the spine, where just because you have degenerative problems doesn't necessarily mean that you require a surgery. So it's always worth a really good trial of care. What's fascinating is you could have somebody who just has a tiny little tear in their labrum, and you're like, this patient's going to get better for sure, and your tools aren't enough, and they end up with surgery. And then you'll have somebody who's got just a massive hip labral tear, dyes going everywhere on their arthrogram, and you're like, there is no way. And they come back in the next visit and they're like, I'm 100% better. And it's hard to reason, why that is, because there's a lot of variables, but it's true. Maybe one thing I've learned, if I get added clinical pearl, is guys do better with labral tears than girls do. And I think it's a soft tissue difference is probably why that is, but it's definitely more common in the female. Okay. These are they getting this presentation or not?
Yeah.
This is, I basically just summed up all the best papers that are talking about femoracetabular impingement if you're interested in those. These are the tests that we use. So really, the most sensitive test you're going to do is, you can see on the far left there, a combination of hip flexion, internal rotation, and adduction. These other tests, not that they're not good, but those aren't the most sensitive and specific. So how you know your patient's getting better, if day 1 you do this and they say, ow, and day 3 you do this and they say, wow, it's quite a bit better, the prognosis of that case is going way up, and that happens most of the time. So that's a good thing. If on the 3rd visit, I start the visit by redoing this test and they're like, nope, feels exactly the same, I got to be honest, in the back of my mind, I'm like, this is probably not going the way that I want it to go. Nothing against the treatment. It's just, that, like Taylor said, it's just sometimes you're not going to get around structure sometimes, unfortunately.
Brad, there's one question in the chat real quick.
Yeah.
Max wants to know if there's a high likelihood of a bone stress response on the femoral neck. I'm guessing with the pincer type of femoral acetabular impingement, but
it hasn't been studied. I don't think that is. I would worry more about that on the angle of inclination, not so much on what we're talking about as far as the femoral acetabular impingement.
Okay, great. Thank you.
I mean, no one's talked about it.
Yeah, it just because it would bring up some questions on treatment modalities and how you approach it if that was the case. That's why I asked it.
Yeah, for sure. Can he have him ask that one more time? So what's the difference what's the difference in femoral neck stress if they have femoral acetabular impingement? Is that the question?
Yeah, essentially. So like if they have bone stress response due to having some type of FAI,
right.
It seems like it would definitely change the management strategy. So it's like oftentimes with hip pathology, you want to load, strengthen, but if they're having bone stress response, it might seem like you want to deload them.
Yeah. I mean,
right?
we were talking over beers. I could theorize that. I can't say that, like, I don't think that would matter so much in clinical practice. It's a good point. But then you'd be dealing with all the consequences of not being weight bearing and doing stuff. And yeah, good question. I honestly don't know. Sorry.
I don't either. That's why I asked.
I think you're going to treat the same way, unless it's like a legit like stress fracture, like the reaction so much that it's acute. But I don't think in like a normal run of the mill FAI case you're going to change much. So.
I mean, one thing we're kind of learning, even like with the current time with COVID and stuff like that, like if we lock ourselves in our houses and don't move our muscles and joints in our body and stuff like that, there's a consequence, you know? So I would hate to shut down a 10-year-old kid in an attempt to save what you're talking about. I don't think like the pros and cons would probably justify it, but it's a really good thought and question. Okay, so I think this is actually a really, really important point. If you look at this picture to the left, I don't remember where I found it, but sometimes you have a thought for years of your life, but you can't find a picture that's trying to tell a story. But what I love about this picture is if you look at the iliopsoas, which is a really, really, obviously really important muscle for hip flexion, as it comes down and comes through the pelvis here, it's not a 90-degree turn, but it takes a pretty good turn around the brim of the pelvis here. And why that's so important is for good economic walking, the reason you want your hip joint to be able to extend is because you want to eccentrically load this mechanism here. It's actually, as crazy as it sounds, like if you look at Basman and DeLuca and like muscle activation and walking, then the glute is actually not what extends the hip in the gait cycle. As crazy as that sounds. I mean, I used to think that myself. But one of the key mechanisms, so you're probably asking, well, why is hip extension important? And the reason hip extension is important is as your femur starts to get behind your torso, you're eccentrically loading up this muscle here. So if you can imagine like a rubber band stretching, and that is eventually you get to a point where you just run out of stretch. And that's when the femur is going to release and you start the swing phase of gait. So, because you might be wondering why do we need hip extension? And it's actually not to activate your glute; it's to eccentrically put tension on your iliopsoas. Now, not surprisingly, we have an epidemic problem with hip joints that are not getting into extension. Like for human walking, they say you only need 10 degrees. We're not getting any because we sit our whole life basically, and the hip joint is never getting put into extension. This is just a cool kind of picture to showing you. You're looking at the back of our right hip here. So if you look at the pull of glute maximus, any joint's main stabilizer is going to be a muscle that runs basically perpendicular to the cut of the joint. So you can see glute maximus so perfectly lines up with the femur and the angle of the hip joint versus like if you look at other muscles, like if you're basically dominating the stability of your hip with your piriformis, look at how that creates kind of an offload, if you will, as far as stabilization. And then another interesting, which I don't see on here, it's probably being blocked, is your TFL. Yeah, so if you look at TFL over here, so you can imagine if your brain cannot activate and control all these different forces, it's one of the reasons why you start to degenerate certain portions of the hip joint. So obviously one of our goals in rehab is to teach our brains how to activate the hips in the best way. We got 18 minutes left. We're
doing great.
But we only have 300 more slides.
I think that's important too, because the name of the game is to create centration of the hip joint, right? So just like with the shoulder, if we're not having that the femur sit in the acetabulum in the most dynamic way through the pull of the glute max and through the pull of those, then we lose that congruency and we lose the dynamic nature of the ball and socket joint in general. And so now like you said, you're degenerating different parts of it, but it creates that kind of abutment and good centration.
And then if you look at primates, you look at like Homo sapiens, we have our pelvis is basically angulated more laterally. So because of that, it requires us for bipedal walking to have muscles that stabilize us in the coronal plane. So we don't see that in other hominoids. Humans are the only ones that have this, and that's what makes us so efficient when we walk on two limbs. However, in saying that, we have to be sure that we don't go too much in the frontal plane. So I'm sure you were taught like Trendelenburg and things like that in school. So basically what ends up happening is if you're unable to use your glute maximus and your glute medius in function, then you'll require a trochanteric shift in the coronal plane. So that's really common. If we watch people stand on one leg, in walking, whatever it might be, they're going to excessively move in the coronal plane. A good way to think of it in the hip joint is they get blocked in the sagittal plane, like they have a tight iliopsoas and maybe an anterior hip capsule. And because of that, they have to move excessively in the coronal plane.
It's after all the muscles.
This is, we're definitely not going to bore you with this, but this is just so you have them, where the trigger points are in the different muscles, because we use these trigger points as audits. It's really, really helpful to know if our treatment's doing what we want. What I love about trigger points is I can feel them and know whether or not the patient's getting better from a musculoskeletal standpoint versus me just asking them if they're better. So like, for example, if you had femoracetabular impingement and I saw you 4 visits down the road and all these trigger points were a lot better, all the range of motion's better, and the patient is continuing to tell me that their pain's the same, I don't like the prognosis of that case. You could also be dealing with like a central nervous system pain issue, maybe. But so if you're doing your job, you're changing function, but the pain syndrome is not matching that, then you may be dealing with structure, a poor structure problem. So I like this picture from McGee because it's what we're going to be doing all day long. So if you look at the hip joint here, you basically, if the patient's laying supine, you load back through axially through the femur, and I always think about 45 degrees each way. So you want to be able to get 45 degrees of motion into internal and external rotation. It's been proven to be a little bit more accurate if you do it with them on their belly, but I always just do whichever way is whatever position the patient's in, just to save time. But we can assess it from both ways. The thing you have to take into consideration is that you're also, you have some knee movement. So that it's not always pure hip motion. Some of it is also coming through the knee. Skip the video. Okay.
Basically, the video, all we did was, it's just showing your assessment basically should include full hip flexion, which you should get close to the chest or to the abdomen. Then you can add an internal external rotation there from a supine position. Then you can check Patrick Faber pretty quickly right there, or the single joint hip adductors. Then you can check the hip two joint hip adductors, and then like modified Thomas, like all the tests that you guys already know, should just be like a quick kind of assessment that you can do pretty dang quick. So.
Because honestly too, and be sure to give Tom Lotus a hard time about this next week. Nothing baffles Tom Lotus more than having a patient that comes in with zero pain. But like, so, but in the athletic world, like you potentially might see somebody who's just there for their body to perform better. So you got to have a family of assessments to know like what what you're going to work on or what you're going to do. So the hip is a great starting point. So, if you're working with athletes and stuff like that, we're going to, I'm just in a habit. I'm checking all of these passive range of motions on just about every single patient. And sometimes I do something with it. Sometimes I don't. It just depends on how big of a deal I think it is in the case and what they require.
I think it's good for young students too. Remember, like, sometimes your patient gets out of pain right away, but that doesn't mean that you've changed the function. You haven't changed the way that they're going to live their life. And so having these simple tests to show them, well, remember, yeah, I'm glad you're feeling better. Remember when we flexed your hip last time, we really, yeah, we've gotten a little bit better range of motion, but we still have some more to accomplish there. I'm still checking on these trigger points here and there. And so it's a constant reminder for yourself that you're not done with that patient, and to the patient that there's still more things we need to work on.
Or here's the biggest hypocrisy and irony there is. All the students who say, I want to treat function, all right? And I deal with this all the time in all my teachings. However, their criteria for whether or not they're going to send a patient away is always going to be pain. It's like the biggest hypocrisy. It's like you're saying that you're a functionalist and you're wanting to change function, but then once the patient comes in and says, oh, I'm 100% better, then you are like, okay, well, just stop everything, get out of here, and you're kicking them out. And I think that's a huge mistake. So and Taylor can attest to this because he's next door to me here. I just keep a lot of my patients with me because I'm constantly working on changing their function. It's really a cool thought. Like, if you think philosophically, when's your patient done? I mean, I don't know. What's your criteria? Is it pain? Is it that they don't have any trigger points in their muscles anymore, that everything is perfect, So sometimes, like, our athletes especially, they just need really good management. And everyone on this that's listening right now is in a perfect position to offer that service if the patient wants it. Not everybody wants that, by the way. Here's that picture we were looking for.
Yeah.
So here's a picture of Trendelenburg. I'm tired of that thought. I'm moving on. Real quickly on the imaging. So the arthrogram is definitely the gold standard to look for femoracetabular impingement with associated labral tearing. However, sometimes insurance is, maybe they don't have insurance, so like a hip arthrogram is going to be too expensive, or maybe they can't use the anesthetics, whatever it might be. So a regular MRI can still be used, not quite as good. X-rays are good for like suspected fractures. You can see some femoracetabular issues on a plain view X-ray also. But just like everywhere else in the body, if we want to see any kind of soft tissue issues, we need to get the MRI. A hip MRI now in St. Louis is going for around $500 or $600 cash. So sometimes I'm just like, screw the X-ray, let's get the MRI. That way we have the whole picture. Because what's really weird here in Missouri is an X-ray series is more expensive sometimes than an MRI. So like, it's messed up. And for what it's worth, there's no radiation obviously with an MRI, and there is with X-ray.
I watched a webinar with Philippon, and he's actually, they're getting close to having some pretty good diagnostic criteria with diagnostic ultrasound too. So, and probably not right now, but in the future, that's something that we could be at hand.
So the thing with the ultrasound, we have a really good department in Logan looking at this, and we've talked a lot with them on some things. What it's really good is it shows you a dynamic picture of what the hip's doing during movement that you can't capture with MRI. So if you're sitting in a tube, we never use an MRI to like assess, movement basically. So anyways, yeah, I think there's probably some promise there. Yeah, we won't talk about all these things here, but this is the assessment for posterior hip capsule. You guys are all familiar with MPI, so this won't be news to you, but basically we're loading back through the femur and we're seeing how well the femur can move posteriorly in the hip joint. Obviously here's the adjustment. So you can do it without the toggle board, but definitely made easier and just more patient friendly with the toggle board. This is long axis distraction. palpation. Here's the adjustment. This is anterior hip capsule palpation. Admittedly, it's a wonky adjustment. Notice I switched tables because it's easier to use like a Thompson drop than it is a toggle board there. This is McKinsey does a variation of this. I actually stole this from a guy named Mike Geraci, who's a medical doctor / PT from Buffalo. And so you can see here, you can use the table to help just kind of mobilize the hip joint into extension. These are our ways to, you can see me doing it on the right here. So a real good functional standing hip flexor stretch in all 3 planes of motion. And then this is me just kind of forcing the patient to get the motions through the hip joint, not through the spinal joints. The big take home, and I learned this from Gary Gray a long time ago, and especially in the lower extremity, whenever possible, you want to stretch / elongate muscles in all 3 planes of motion. So here's transverse. That would be sagittal. And then that's coronal. You can talk about.
Yeah, so MDT wise, derangements happen in the hip too. So when it's not coming to the spine, these are kind of your most reductive movements, starting with pure hip extension. And so, if you look all the way on the left, that's kind of our starting point. And then all the way on the right is just a little alternative to get a little bit more stretch. And then if you exhaust extension and you're still not getting that localization or kind of the full range of motion, then you can go and add a little internal rotation and stay sagittal. So the biggest loss of range of motion you're going to find though is flexion and extension. More times than not, extension is what you want to you're going to go after first though.
And this is not rocket science. If you looked at MDT and you find all the key reductive movements of whatever joint we're talking about, it's always going to be the movements that joint is not going in. Remember I said earlier, we sit our whole lives with our hips in passive flexion. So it shouldn't shock us that we can get a lot of miracles with hip extension, right? Same thing like with the foot and ankle. So the key movement is recovering dorsiflexion, because I'm looking at Taylor right now. Both of his ankles are in plantar flexion right now as he's sitting, all right? Or like when you're walking. So as you're, going through your gait cycle, your ankle is moving in plantar flexion. So the key reductive movement oftentimes in the foot and ankle is going to be dorsiflexion. And we could go through every joint, but that's the reason why. Okay, so now we start to put our DNS hat on. So here's some of the different mobilizations that if you've come to a course, you see us teach, especially in exercise 2 or DNS-B. So these are just like clinical gold, not just for hip problems, but for anything. Any patient that you're treating for anything will be better off for you finishing the treatment with some of these mobilizations here. And then here's Tony doing a DNS move. So this is, we call this a DNS transition that would equate to around 7 to 8.5 months of development here. So it's a really, really good way to turn on the muscles around the side of the hip, that being glute medius and the posterior hip also. These are, think of it as old school, maybe more functional, dynamic, whatever you want to say. But anyways, we can, if you don't know DNS, then we can get after the same type things with here, like a loaded bridge, a one-leg bridge, maybe a clam exercise, or a monster walk. So before there was DNS, there was me teaching this to our patients. So, these shouldn't be forgotten. These really stem from still the Prague school, but more like Vladimir Yanda's time, where he thought of all these different ways to activate the muscles around the hip.
I think an important point too, though, the intra-abdominal pressure is not lost on these. So these without intra-abdominal pressure are way less effective than if you teach intra-abdominal pressure and movement in general with these. So don't lose sight of that.
Yeah, for example, I think everybody who's listening to this, you've done a glute bridge and your hamstrings have started to cramp. One way to get around that is to have better intra-abdominal pressure. So, because once you have better intra-abdominal pressure, your brain will be less likely to activate the hamstrings. And then this would be like, as we said before, like really moving them down the continuum of treatment. So now they're outside of treatment and now they're training. This is Natalie, one of our stud trainers. and she's going to be showing a single.
When doing a single leg RDL, we want to think about having our shoulder blades back and down. They can keep big pressure in our belly. Then we want to keep our back nice and flat. Then from here, we're just going to think hinge our hips, go straight down, and then use our momentum to bring ourselves back up.
I think we have a goblet squat on the horizon here.
Okay, so for a goblet squat, we want to think feet a little wider than shoulder width apart. We want to think knees stay tracking with our ankles. We want to think big pressure in our belly. Then from here, you're going to think sit straight down, keeping that spine nice and neutral, all the way back up, straight down, all the way to your heels, back up again.
This is really, really good for like people who also have like tightness in their adductors. So I think goblet squat it's one of the safest and best squat patterns that we can train. Mm-hmm. So these are the references we've used. I don't have words to describe how great I think Dave McGee's orthopedic textbook is. I mean, the more I get into it, the better I think it is.
It's insane too. It goes by body part. It's so good. They're coming out with a new edition in October. So
yeah, so maybe you want to hold off until then to get the book or get a real cheap one maybe online. Because honestly, as the editions have gone on, I have all of them. There hasn't been that much change, quite honestly. Craig's book, the 3rd edition. One thing I love about Craig's books, Rehab of the Spine, is they're never the same. So I would not say that to be true here. I mean, I feel like the 3rd edition compared to the 1st edition of Rehab of the Spine, it's like 2 completely different books in a good way. So I think that's a great book. And then
he's just saying that because he's got a couple chapters in it. So.
Well, I'm a little biased, but so then Newman's book, just the best pictures. I think whenever we can make anatomy more interactive and with good pictures, good videos, it makes it easier to learn. And I think Newman is he's got the best pictures. I also like Kapanji, which we don't have that up there, but. We did it. We have 1 minute left. So we'll take questions for the next 19 seconds. Now we have time for a couple questions. So.
Or not. That's okay too. I will plug Logan MPI is having a happy hour tonight at 6:30. I think 6:30 on Zoom. So Forrest Allen and Nick Hedges. So it'll be a riot.
You will not be sober for that.
It'll be a riot. So tune into that. And is there any other questions?
Yeah, I got a question. I'll ask one. What do you find is the most difficult or possibly the most fool's gold when trying to differentiate the hip?
I would say, probably the thing that would be hard for a typical student would be like lumbar spine hip, for sure, 100%. I can even with, even being old and seasoned like I am, I can still find myself getting tricked even on that. The other thing would be, I guess the thing I always wrestle with, one thing I take really seriously is the step when I take somebody to surgery. So I think of my job as I need to be world-class at my ability to vet them out, because we know the imaging is part of the picture, but if it was as simple as saying, oh, this is a horrible labral tear, go have surgery. Well, that's what we do. Well, we've learned that doesn't work in the human body, and so I would just say to another point to your question would be that's also challenging for me, is like knowing for sure that I am not going to get this patient better, and then being confident that they wouldn't walk to you, Max, and then have a miracle with you, and so something that I missed. So I want to be sure that I have made sure that they're not going to get better conservatively, and that they are in fact ready for surgery. I think those are probably the 2 biggest problems people run into with treatment of the hip.
I'll add in patience to that. Just having patience in a case and not getting ahead of yourself. So to kind of Brett's point, that's something I struggle with all the time, and Brett's is classy to remind me of that every once in a while. But just having the patience to know that, this person's been in my life for 2 weeks, but most people are going to get better regardless in 6 weeks, right? If it's just a normal musculoskeletal case, they're going to get better. So they're better off getting better with you than to get better with someone else, especially if it doesn't look like it's going down a surgical case or anything like that. And I think maybe the one thing we didn't add in was a limp with pediatric patients.
Yeah, that's never a good thing. So if you're treating pediatrics and you have an unexplained limp, do not put your hands on them. Send them for imaging immediately of their pelvis and hip.
Phenomenal. Thank you.
Yeah.
I have a question kind of going off of that limp. What are your thoughts on leg length? When do you kind of prescribe a heel lift? And
the research says there needs to be a difference of 5 millimeters or more for it to be significant. I think it's actually probably a little bit greater than that. It is, what's hard to know is like what's true functional leg length difference versus structure. So you can do, it's called a scanogram. So a scanogram is like an official x-ray basically to determine what the actual difference is. So like in the hip, like if you have a snapping hip in a kid, until proven otherwise, you're dealing with probably a structural leg length inequality. I've seen some crazy ones. I've seen like a 1 to 2 inch difference, and the kid and the parent did not know that. And what's crazy is you put the lift in, and by the way, if you do want to lift it, you lift the whole sole of the foot, not just the heel. Then immediately the hip goes away without even treatment, or the pop goes away without treatment. So I would say one thing to notice is when you're working with them before and after your treatment, notice if you're able to change it. If you're able to change it, it tells you there's probably a dynamic component to it. If they keep coming back and it just looks exactly the same, then you could start to head down that path. The other thing, and this kind of blew my mind, and I can't believe I am admitting this, but research proved me wrong. I thought that if you measured from the ASIS to the medial malleolus, that would be an absolute horrible way to determine whether or not there's structural leg length inequality. I just would have thought there'd be all kinds of error with that. It's actually really specific and sensitive to do that, which I still don't understand it. But anyways, they looked at it from a research standpoint. So you could also measure it. Another thought is, you're going to be hard to find the human being that's walking around that's got perfect length of their limbs, because you're assuming that every bone's the same length. That angle of anteversion that we looked at, that also determines bone length, muscle tension. So there's a lot of things that can alter it.
Yeah, asymmetry is the norm, I think, is another way of putting that is you're going to have asymmetries in every single person that you look at. That's normal, though. I
think, Jake, though, the minimal amount to start looking at it would be 5 millimeters. And I think 10 millimeters is probably where you'd really start looking at it probably.
Do you find any like typical patterns with, if you're treating them for like 2 weeks and then you find any typical patterns, or like this person might have a serious leg length discrepancy, and then, or do you kind of just rule it out right away?
Well, because when you're going to be joint playing everything anyways, so like on the day one, when you're like getting down to the lower extremity, you'd be a fool not to just right at that point when you're looking down, like see if and I'm just in a habit of looking, there's certain things that like are just burned in my cortex, and no matter what, I'm going to look at. When I'm palpating their cervical spine, I'm going to sneak my fingers around and make sure they don't have a goiter of their thyroid. That way I couldn't like pick up on thyroid cancer, for example. Like there's just certain things that I am not going to miss, because I'm just kind of used to looking at it all the time, and that's one of them. So when you start your joint plays of your lower extremity, like I'm sure Corey might have talked about, then when you in that habit, that's the time that you would actually look for it. Maybe you'll do it supine, maybe you could do it prone, and however you're most comfortable looking at it. I always reference the highest point of the medial malleolus, though. That's always what I'm looking for to see when I'm comparing side to side.
All right, thank you.
But no patterns, because everyone adapts differently. So unfortunately, you're really not going to find like across the board that they have the same trigger points in their adductor longus on the short limb. It's not going to be like that. And I bet that was kind of the origin of your question, and that you won't find that to be true. There's a guy named Porterfield in DeRosa, though. He wrote a book called Functional Perspective of the Lumbar Spine. He's actually got a whole section on what you're talking about. And he does kind of cookie cutter it out a little bit. So that might be a reference for you in that textbook if you want to look more into that.
Thanks.
Yeah.
If you have like an athlete, like a runner or an athlete of that sort, are you ever training or rehabbing the glutes as a prime mover with glute ham raises or reverse hypers, as opposed to like the glutes being stabilizers with DNS and those types of rehab?
I find myself not doing that, and I never know, because like what's been hard for me is people who do that, they oftentimes don't have a DNS background, so I never know whether or not to 100% buy into that if we don't have the right pattern put in first. I think it could be done. I would just say let's just say we're talking about like an extension, like a Sorensen's test. I don't know, or like a good morning, for example. Like those exercises with intra-abdominal pressure could actually be magical in training. But then like if the concept of intra-abdominal pressure and joint centration is not there, then you're probably teaching them to compensate better for whatever issue they have underlying, which might not be better.
Yeah, and just speaking, so when I go to the high school, I'm in the weight room, and so I have to put up with watching them work out and stuff. And so they're doing so much prime mover stuff with their lower extremities that I would rather try to put them in a good pattern to get their neurology in the right way. That way, when they do those things that they're already going to do, hopefully that pattern is stuck with it, and then we're kind of giving a better prime. I just think that your time is better spent in grading the pattern or grooving the pattern, like McGill said, than trying to do those big things.
Yeah, because I mean, one thing I think that has been really good that you've heard a lot in the last 5 years is teaching people to be anti-fragile, which I really do like that. I think even like we were guilty of that early on in DNS and our teaching of like basically people were afraid to move because you were out of joint centration. So I think in saying that, we can use traditional movements and lifts. We just got to be a little bit careful. And, you know, those things can be made great, honestly, like as long as there's some real simple principles put in. Or you can think of yourself as, you know, like if they did a DNS routine or flow before their workout, think of it like an insurance policy. When they're going to work out, they're using all their superficial global movers. And then, you know, before they work out, they've activated all their deeper phasic stabilizing muscles. And that's another way to go about it.
Yeah. Yeah, that sounds good. Thanks.
Yeah.
Rock and roll.
I've actually got one more question kind of based off of that. Do you have any typical DNS exercises that you kind of give your athletes who struggle from hip problems before they go and work out? What would you kind of give them as just a pre-exercise plan?
Oh yeah. Let me just show you this one.
Right.
This is one of, I feel like we should write a DNS book and say, these are the magical movements. This is one of them. Like this is, I think the reason it's so great is because it goes home relatively well too. So like, you know, you have a 5-minute investment in your time treating to the patient. They have this exercise for the rest of their life, but things can fall apart here. So the thing you got to watch out is make sure like the rib cage and pelvis are together. There's intra-abdominal pressure. And what's fascinating, if you just like get sloppy with what I just talked about, you can actually feel how they don't activate the right muscles around the hip. What you'll feel is like if I let Tony get into a big old anterior pelvic tilt here and I feel around his hip and pelvis, you'll feel his TFL just really get activated. You won't feel as much activation of all the muscles around on the glutes. And an important point on this, you can't really like see it as he's moving. This is a 3-dimensional movement. the glute is a multi-pinnate muscle with like multiple different fibers and innervations. So we want to be sure we're adding that rotational component. So like people, a lot of times they'll leave a DNS seminar, people who are bastardizing DNS, you'll see them just kind of going up and down in the coronal plane and not training this key rotational move. But to answer your question, it would be this exercise.
Thanks.
Yeah.
Rock and roll.
Just kind of going off that, if I can ask a quick question.
Yeah.
Would you give this side bridge for like a weightlifting athlete, someone that spends a lot of time in the deep squat and trying to get their like rib cage over pelvis stacked as they're sitting in the bottom of the squat, maybe like carrying a snatch or something?
Yep. So the only difference is going to be that group of people requires really good education. Like they just want to bypass this, has been my experience. So it's just as important, some would argue way more important for them, because now you're starting to hear like a lot of these weightlifters, at least in powerlifting, talk about like they were originally trained to have their feet really wide apart with a lot of external rotation. And although that was an important from an engineering standpoint, as far as like a wider base of support, the downside was it really kind of loaded the hip joint in a non-efficient way. So I would say that, you know, the people who are really intelligent in that world, like they're starting to learn that foot position and stuff like that can be important, but also like DNS exercises are also really important because it's basically putting the right pattern in before they go do their big lift. And that would be exactly how I'd motivate them. I would just say, what you're doing is amazing. You're strong. You're way stronger than I would ever be. However, your brain right now is not great at activating all the fibers. And here's where you'll get them. The next thing that I'm going to say is, you would say, this will actually make you stronger because now your brain is able to activate more neurons, you know, however you want to word it to make him understand it. But that you gotta, it's a little bit different than working with your typical patient because they have a tendency to not want to do exercises like this. So you gotta figure out how to motivate them.
The other good position would be like 3 months supine, like differentiating hip movement from like lumbar spine movement would also be like a really good way.
Cool.
What a pleasure, guys.
Yeah.
Thank you so much.
Yeah, if there's no more questions. Awesome. Yeah, if there's no more questions, thank you very much for coming on and doing this. It was great.
Yeah, thanks for having us again. We really, really appreciate it.
Yeah, keep doing awesome things. I'm gonna go destroy this dude in bags.
Sounds good.
All right,
Later, guys.
Yeah, we'll see you guys. Thanks.